Thank you. Thank you so much. So, my topic is titled The Initial Baby Steps of Phaco with MIGS. So, the MIGS wave is here. So, if you want to ride it, you've got to learn how to do it. So, and the good time is now because we don't know what the future of MIGS is, but at the moment, it's definitely a hot topic. So, regarding the initial baby steps, the first is the microscope and the patient preparation. Now, that's very, very important and key to doing a good MIG surgery. So, we are all using, either a Lumera or a very high-end microscope. So, what you've got to do is you've got to mark it because the positioning of the microscope and the patient is very, very important. So, during MIGS, you've got to tilt the microscope towards you. You've got to tilt the head of the patient away from you. So the microscope is yours, so that has to be tilted towards you, and the head of the patient has to be tilted away from you. So what you can do is you can use an app to mark the degree of tilt so that next time you don't have to do it. You just got to align it, and then you got to push the head of the patient away from you. So, the tilt is a 30-degree tilt of the microscope towards you and a 30-degree head tilt of the patient away from you. Some say it's a 30 towards you and a 40 tilt of the head away from you. Some say it's a 30 towards you and a 45 away from you. But it's more about doing it. So you got to reduce your chair height way below the normal phaco surgery. So you reduce your chair height, tilt the microscope towards you, tilt the patient's head away from you. Otherwise, you're not going to get the en face view of the angle. Now, once you've achieved this, you've got to enter post phaco and try to bring the size of the pupil down. Because during cataract surgery, we all say, pupil ta choto kano. Here you want the pupil to be small. But the moment you use a viscoelastic, so here what we prefer is hyaluron, which is 1.4% sodium hyaluronate. Now once you inject viscoelastic, immediately the pupil is going to dilate again a little bit, but that's not going to hamper it. You've got to put a blob of the same viscoelastic, and then you're going to use a gonio lens. Now there are these 4 gonio lenses which are currently in vogue. One is the Swan-Jacob gonio lens. Now that costs around 1,25,000. So if you have it, it's great because it's a one-time investment. You can autoclave it and keep on using it. The second is something called the iPrism SX. It's a very small instrument. It's made of PMMA. And ideally it's disposable after every case, but you can easily use it for 15 to 20 cases. So that's what we're doing it. Make sure to wash the viscoelastic off, and then you can ETO it and keep on using it. The third is something called the Moria ocular gonio lens. Again, that's extremely expensive. That's more than 2 lakhs. And the fourth is something which is a hands-free, just like a biome. You can attach it. That's from Oculus. It's called Oculus Gonio Ready. So you don't need to, you'll have both your hands free. Now once you have either of these, you can fix it, and you've got to tilt the head post phaco until you get this particular en face view. Now once you get this en face view, after every phaco case, try to use a spatula and just touch the trabecular meshwork and come out. So that is all you've got to do for your initial thing. So you can either try a lateral movement as if you're stripping, or you can just touch it and come out as if you're doing a stenting. So any of these 2 procedures. So here, I'm kind of going, touching it, and I'm trying to practice, doing an eye stent. Or I can just, make a lateral movement. So these are some of the initial cases that I used to do. After every phaco, I'll go back in, I'll put viscoelastic, and I'll try and just touch the trabecular meshwork and come out. So this is a very good way to learn, A, how to get the view, B, your hand movements, because you're going to land in a soup if you start doing it suddenly. So there are these 4 MIGS procedures which are now in vogue. First of which is extremely simple to do. That's called a bang. So all you need for this is a 25 gauge needle or a 24 gauge needle. You bend it so that just the tip is bent. You don't have to use a lot of force. Remember, it has to be very gentle. So you can just try and strip even a little bit. So you can see you can see the tip. You don't have to go deep. You're going to create a false passage. So you may have these initial hiccups, but once you do that, you'll see a very clear whitish patch showing through. That is the end point. You don't have to go on stripping it. It's just a very gentle strip. That is all you have to do. So initially you can try just for 90° and leave it. Nothing is going to happen. And then gradually increase to 120 and go on increasing it. And put a viscoelastic so that you can see that white zone. That is all you need. That you've stripped the trabecular meshwork off. So it's just a very, very gentle strip. And as you keep on doing it, sorry, that is kind of blocking the view. So, it's just, so this is the third or the fourth case. So you just a gentle strip. Now, once you're very comfortable with this, you can shift to something called the KDB. So this is a very wonderful instrument. The advantage of this is that it has a tip and it has got these ramps. Now the ramps are cutting blades which can be used to make a very clean strip. So if you look at it, you just introduce the instrument, and again here you can see blood in the Schlemm canal. So you just strip it. It's a very gentle strip. So here I've just stopped it midway to come out and just show you that white colored area that you can see. So it's a very, very gentle strip. So once you're proficient with it, you can go from one end and you can just strip the entire 120° or even further with just one go, and it cuts very smoothly like a knife through butter. And again, you'll see that very clear white strip. Now once you've completed that, you can move on to the eye stent. So I'll just, 1 minute I think. So this is it's an extremely expensive instrument. However, the West Bengal Health Scheme and the CGHS, they've approved it. So you can start doing it. Initially, you're going to have a problem with the view, but the instrument, I borrowed a video from Tanya. So you can see initially, you just have to introduce it. It may bleed quite a lot. So be very fast in doing both one after the other. If you wait, as in this particular case, you'll see that, post, now this is the video which I borrowed from Tanya. You can see the trocar. The eye stent is threaded onto the trocar. You just push it and it goes and it gets delivered.
Arijit, can you
Yeah, and the last but not the least is another video which we currently in West Bengal are not doing, something called GAT. Again, it's very, very inexpensive. You can take a polypropylene suture, mushroom the head with a cautery, and then you make a nick into the trabecular meshwork, and you can use a Grisheba forceps to introduce it. You can see the mushroom tip. Be very careful because it can create a false passage. So this just goes in 360°. Again, it looks very simple, but this is probably the hardest of all the four. So you just keep on this continuous motion, comes out to the other side, and you can strip it off.
beautiful
Thank you.
videos? Thank you so much, Arijit. So just tell me, what is the learning curve? What is the learning curve of this procedure that you said?
So I think the primary learning curve would be to position the head of the patient. So that takes a lot of doing, especially for people who are not doing gonioscopy. So that is going to take a month or two to get adjusted to that. Do the last couple of cases of phaco and then try to do that. Once you do that, a bang is a very, very easy procedure to do. So maybe within 3 to 4 months,
And
you'll be able
if
to
one does
get
not
ahead.
want to buy those prisms or lenses,
Yeah.
so how do they get them for practice?
That's a tough question because
It's a tough one. Okay.
the eye prism SX is relatively
I think
cheap.
we
That's
have the
5,000.
master here, Dr. Anil
Anil
Mondal.
Mondal, sir.
Please.
Arijit, I
Yes.
have a basic, confusion, controversy about mixing phacoemulsification with minimally invasive glaucoma surgery.
True, sir.
The very idea of minimally invasive is the least manipulation intraocularly.
Correct.
When you are doing phaco, I don't see any reason that it has to be, glaucoma surgery has to be minimally invasive, because the most invasive surgery you have done already. However, there are several advancement of this kind coming, but it has to be evaluated against the standard surgery of phacoemulsification with trabeculectomy. So those kind of authentic reports are still awaiting in the literature. Unless those comes, we really cannot tell. However, whatever Arijit has presented is an elegant technique. Glaucoma surgeons should learn it and then plan about their management.
Dr. Manish, your comments?
I think Arijit has already highlighted the very important point that more than the actual surgery, the visualization is something we should take time, try to practice it. In fact, most of our cases where we have complication like too much of bleeding or say a cyclodiasis cleft we created or we injured the ciliary body, the primary problem was poor visualization. So if you have a good visualization, but I agree to Mandal sir, we still don't have enough data of making patients spend lakhs of rupees for maybe 2 millimeter of extra IP reduction. So we still need more, but I think Arijit what has highlighted, bang is a very good procedure, totally cost effective, and it's actually quite useful in certain patients, so it can be tried definitely.
Well done, Arijit. Thank